Dr. Ilham is a well-known pediatric ophthalmology and strabismus consultant. She had her bachelor degree in medicine and surgery from King Saud University. Then she joined Riyadh Ophthalmology Residency Program and graduated in 2010. She has the Saudi board and Jordanian board in ophthalmology, as well as a fellowship in ophthalmology from King Saud University. In 2014, she finished her clinical fellowship in pediatric ophthalmology and strabismus at the University of British Columbia, Vancouver in Canada. Dr. Al-Kahtani had many publications and presentations in scientific meetings. Also, she was assistant professor at King Saud University before joining her current job. Currently, she's pediatric ophthalmology and strabismus consultant at King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Ilham, welcome again, and thank you for being with us. The mic is yours.
Good afternoon, everyone. Thank you, Dr. Abdallah, for the nice introduction. It's my pleasure to be with you today to share with you this grand round. I will talk about the normal changes in refraction and the phenomena of emmetropization. I will briefly discuss hypermetropia and astigmatism, and I will concentrate on the myopia epidemic, which is affecting many parts of the world, causes and its possible treatments. This is a meta-analysis study published in 2013, in which they reviewed 15,000 papers and used 243 population. This study is published between 1990 and 2010. And they define the moderate and severe visual impairment, where the vision worse than 20/60, greater than 2400, and the word blindness when the vision worse than 2400. It was estimated that in 2010, there were almost 7 million blind and 101 million visually impaired people. Uncorrected visual errors was the cause of blindness for 20%, and for about half of the patients with moderate to severe visual impairment, the cause was uncorrected refractive error. They concluded that in 2010, uncorrected refractive error were the most important cause of moderate visual impairment and the second most important cause of blindness. We all know there are 3 types of refractive errors: hypermetropia, astigmatism, and myopia. I will mainly discuss myopia because of its public health relevance, particularly in Asia countries. There are 3 parameters are involved: corneal curvature, lens power, and the axial length. These graphs show changes of refraction in the first 3 years of life. At age 3 months, the refractive error is distributed normally with a slightly hypermetropic mean around 2. With age, the curve becomes steeper as patients clusters around the low hypermetropic average, and there are a few apparent values on the hypermetropic side, and these are responsible for the patients frequenting our clinics with strabismus or amblyopia. Hypermetropia is of the greatest concern, and many of us spend our days looking after the consequences of hypermetropia. It causes anisometropia, hypermetropia, which is the powerful cause of amblyopia, accommodative esotropia, occasionally bilateral amblyopia, and symmetrical hypermetropia. I don't know why this, okay. Hypermetropia presents screening challenges. Failure to an early detection often results in irreversible amblyopia in visual adult population. So the usage of cycloplegic drops is a must. At 6 years of age, children from Japan, Australia, Ireland have similar refractive errors. The Japanese have lower hyperopia, but they are not myopic yet. The development of myopia has not started yet, even in the Japanese group, around the age of 6 years. The low incidence of myopia at age 6 compared to older age indicates that the vast majority of myopia develops in eyes that have successfully emmetropized early in life. So myopia, therefore, is the most commonly due to secondary failure of emmetropization mechanism to maintain emmetropia or low hyperopia. In older children aged between 11 to 13, we start to witness a shift toward myopia, more pronounced in certain populations. This Japanese study, published in 1999, shows us that the incidence of myopia up to age 6 is very little, but starting from this age, there is an obvious shift toward myopia. We can also see that this myopic tendency has increased with time from 1984 and 12 years later in 1996. "70 years ago, myopia was thought to be a largely genetic phenomenon. Increasingly, the important environmental contribution has been recognized. The studies in primates showed that the axial growth could be induced by defocus. The very low incidence of myopia in Inuits who grew up in isolated countries and very high on their children and grandchildren can't be explained by genetic changes, as they happen very slowly. In Omnium describes 269 genetic conditions associated with myopia, such as Stickler and Marfan. So genetic myopia tends to occur at younger age than environmental induced myopia. The school myopia, which has increased greatly in prevalence, that its development is correlated with years of schooling and academic results. So myopia increase is well recognized in certain groups, such as Orthodox Jewish boys who spend most of their days studying religious texts. The average 15-year-old in Shanghai spent 14 hours per week on homework compared to 5 hours in UK. In high-income Asian countries like Singapore, South Korea, China, which have intense educational pressure, the vast majority is myopic by the time they leave school at 18. Countries with the highest incidence of myopia are colored red on this world map. The rapid increase in the prevalence of myopia seen over the past few decades in East Asia can't be explained by genetics. High myopia has serious implications, and it often leads to visual morbidity, such as glaucoma, cataract, choroidal neovascularization, macular scar, staphyloma, retinal tears, and detachment. They projected the changes in prevalence over the next 35 years and concluded that if trends continue, half of the population will be myopic in 2050, 5 billion people and 1 billion highly myopic. How can we alter this grim future? there is no evidence that under correction may slow myopia progression. It's important to cycloplegic children to avoid overcorrection. In JAMA Ophthalmology 2014, they published 128 Chinese Canadian children, the range between 8 to 13, and their myopia mean was -3. The inclusion criteria was high rate of myopia progression. And some of the patients, they divide them into 3 groups, given to single vision, bifocal executive, or bifocal with base and prism of a 3. And the high rate of myopia progression was defined as 0.5 or more diopter increase in the preceding year. The prism were used to reduce the accommodative lag. And this study, they found the bifocal slowed the progression of myopia by 50%. Also, bifocal contact lens have a similar effect. In this randomized controlled trial, it was over 1 year prospective, included 86 myopic children, age ranged between 8 to 18. The mean refractive error was -2.69. They found the reduction in progression of the myopia and the axial length. A 5-year study published in 2015 observed a decrease of myopia controlled over time after 4 years reduction of 30%. In Ortho K group, refractive error decreased from -1.8 to -0.7. And in the control group, the refractive error increased from -1.83 to -5. The mechanism by which the Ortho K control myopia is still unknown. It has been postulated that peripheral myopia created by Ortho K, the steeper cornea in the periphery, reduce the periphery hyperopic defocus, and this may reduce feedback for eye elongation and the changes on the corneal power. Although the risk of infection is little according to the most study from the Ortho K, but still very serious, and it could result in irreversible vision loss, like acanthamoeba and pseudomonas, most common agents in using of Ortho K. Atropine drops have been used to slow the progression of myopia for about 150 conducted one of the first long-term studies on its use to slow myopic progression. How does atropine act to slow the myopia? It was always assumed that it was by preventing accommodation. However, ablation of edgunar-westphal nucleus doesn't abolish the effect of atropine on myopic progression. So does it have another effect? Atropine may inhibit thinning and stretching of sclera and therefore the eye growth. The classic randomized double-blind study on atropine for myopia was published in 2006, called ATOM, which is for atropine for treatment of childhood myopia. The treatment group given atropine 1%, both eyes fully corrected optically, and the treatment eye had a significant smaller axial growth and no myopia progression during the study time. The clinical efficacy of atropine 1% was established for short-term use with this study, but atropine 1% caused important adverse effects. In this meta-analysis of 19 randomized trial involved 3,137 children, only used refraction to compare as axial elongation was only evaluated in patients with high-dose atropine. After cessation of atropine drops, the previously treated eye have a progression of myopia of minus 1.15, whereas untreated eye showed a myopic progression of minus 0.38. And this is called rebound after discontinuation. Lower concentration of atropine will avoid cycloplegic blur, mydriasis, and photophobia. In this study, ATOM2, they use 0.01% of the atropine, and they compare it with the effect of the atropine 1%. And they found, this study, they showed the lower dose of atropine are much more tolerable and equally efficient in controlling myopia progression. 400 children that had -2 or more of myopia were selected in this study and showed 56% have to treated in phase 3, where 24% of 0.01 group and 59% of 0.1 group and 68% of 0.5% group. In the phase 2, children who were received higher dose of atropine had a rapid increase in myopia, whereas the children treated with lowest dose had little increase. So the atropine 0.01% seemed to slow myopia progression by 50%. The result after a 5 years follow-up, they found the 0.01% atropine is more effective in reducing myopia at age of 5. Retreatment is as effective as a primary treatment when needed. Clinician may stop and restart treatment according to individual progression rates. In children who respond poorly to atropine, progression more than 0.75 per year in the second year, treatment should be discontinued. In this randomized controlled trial, they selected children between the age between 8 to 12 and included 117 patients given pyranozapine and 57 placebo over 1 year follow-up. Pyranozapine is other muscarinic antagonist and shown to be effective in slowing myopia progression. They concluded that 2% of pyranozapine slowed myopia progression by 50% in those patients. In this study, it is meta-analysis and systemic review of 25 papers. They found the time spent outdoor will reduce the onset of the myopia, reduce the risk of onset by 50%, and the time spent outdoors is associated with less myopic refraction regardless of the activity performed, reading or sport engagement. As you know, the bright light induced production of dopamine, and they found dopamine could be implicated in this effect. In conclusion, uncorrected refractive error is a major preventable cause of visual impairment and blindness. Myopia in Eastern young Asian has reached epidemic proportions with warning long-term implication for ocular morbidity. Lifestyle modification with early intervention in childhood is urgent. Full correction, the current recommendations, full correction with the glasses or contact lens, encourage outdoor activities from early childhood, encouraging the outdoor activities before myopia develop is very important. Bifocal glasses or contact lens it's better to avoid Ortho K, Atropine 0.01% for progression myopia or its analog. Those are the references, and thank you for the attendance.
Thank you, Dr. for this great presentation. Now I will open the floor for comments or any question. So let me start, Dr. Ilham. So do you usually, like we see in our clinics, a lot of myopic patients, children, but do you usually start giving them atropine as a usual practice?
It depends on the patient. So if you have usually patients at age of 6 with progression, you see progression in the myopia from the 2nd year, and he has no other underlying cause like genetics problem like Marfan or Stickler. So you can start to use the atropine, the weakest dose, the 0.01%.
Yeah, correct.
To slow the progression of myopia, especially if you have, if you see the progression from each visit.
I see, sure. So anyone has any comment or question?
Assalamu alaikum.
Thank
you, Dr. Ilham. Very interesting topic, and as you may all know, it's a very hot topic in pediatric ophthalmology, the use of atropine to try to control the progression of myopia. As mentioned by Dr. Ilham, myopia has become a worldwide epidemic, especially in the Asian countries. And in Saudi Arabia, I think 1 or 2 studies came out from the worldwide regarding the increase of myopia over the last year during the corona epidemic. And a lot of people have linked that to the indoor activities of the most of the children are studying online. So the problem with myopia has become worse. Now regarding the how does atropine work? I think there were a couple of theories. One of them was already mentioned by Dr. Ilham, that it directly works on the sclera by inhibiting the glycosamine glycan synthesis via its non-muscarinic effect. But there is also the possibility that the mechanism of action of atropine goes by at the retinal levels. I think it's at the molar cells level. The side effect of atropine is related, obviously, as mentioned, to the concentration. We have to remember that we got a better effect with 1% atropine, but at the same time we will have a stronger rebound phenomena. Most of the authorities now are suggesting the use of atropine of a minimal of 2 years, because they have seen that after the 2 years treatment and then following up the patient with a 1 year washout time, there was a very strong rebound phenomena, and the rebound phenomena is related to the strength of atropine that's been used. Although the 0.1% atropine had a less effect on myopia progression, but it has the least rebound as well, phenomena as well. The other point mentioned regarding the environmental factors, a couple of studies came out, the COMET study 1 and 2, and both of them examined the effect of near work and outdoor activities on myopia progression. I think they did not come up with convincing conclusion. I was looking at their conclusion, and it says that neither near work nor outdoor time activities have a strong effect on myopia progression. The result was not consistent and clinically non-meaningful. The outdoor time was consistently related to the onset of myopia, but it has no effect on progression. So it looks like that myopia will eventually be related to genetic factors rather than outdoor activities. And when we examine the effect of near work or outdoor activities, we're looking for near work at the time the child spent using is studying, for example, or iPads, at the distance that he is away from the near work activity, and the break that he takes while doing his near work activity. The result was not conclusive, as I mentioned, and was not convincing. And it looks like their recommendation was we should focus on the optical intervention, which is in the form of the Ortho K. The Ortho K should be used with caution. However, in the Blink study that came out lately, the rate of complication with the Ortho K was really low comparing to the number of patients who were using it. The other method was to try to do the peripheral defocusing of the image by the specially designed glasses for myopia control. We have different glasses in the markets, and by using the soft contact lenses like the My Vision type, or the one which has bifocal contact lenses. So thank you, Dr. Ilham. This was really useful, and I really enjoyed your talk. Thank you.
Thank you, Dr. Amal, for your comments.
Thank you, Dr. Amal. I can see there is comments in the chat. Dr. Sisma asked, do you prepare yourself the atropine, or how to prepare it as a 0.01%? As I think, at least in KKH, I'm not sure if we have this percentage as ready medication.
Actually, in our hospital, we have the 0.5% of atropine drops. I'm not sure about how to prepare the 0.01%. But I think sometimes from the pharmacy, they can do their calculation and concentration to make it. But for sure, 0.5% is available in most of the hospitals.
Can I comment, Dr. Abdullah?
Yes, sure.
We in private, I was able to convince my pharmacy to prepare it, the 0.1% atropine, which is they prepare it from the commercially available, I think, from the atropine ampoules, and under there's special instructions to prepare it, but we don't have it commercially available. In Prince Sultan, we were also able to prepare the 0.1% from our pharmacy. So I know of two places where it's available, from Prince Sultan Medical City and from private. Habib Hospital is preparing it. I think also there were a couple of other private centers, they were preparing it in the pharmacy. I know in Asia and other countries, like in Singapore, I think they have all the dilutions ready. They are lucky. They have the 0.1%. They have the 0.5%. They have the 0.01%. They have it commercially available. But I think this is because of the fact that myopia in their countries is basically an epidemic. So several companies agreed to prepare these drops commercially available. Now the preparation from the pharmacy, I think it does not have preservative. So patients have to take a bottle, I think every 10 days or every 2 weeks maximum, to get a fresh bottle. So this constitutes a problem. We are currently running a study both in Habib Hospital and in Prince Sultan on the response of our patient to atropine, 0.1%. We haven't looked at our data yet because we have just started. In my private, I have almost 100 patients who on or more on atropine, whom I have been following up for the past 1 year. I didn't look at my results yet, but it looks promising. I know of also a company in India that is preparing, that has it commercially available, and in Turkey. So we have it available in few countries, but unfortunately in Saudi Arabia we don't have it so far.
I see. Thank you, Dr. Amal, for this input. This will bring us to another question. Can take it. For how long we can use it, especially for Dr. Iman or Dr. Amal, anyone who has experience with it, for how long we can use the atropine?
Should be for 2 years, not less than 2 years. Then the gradual decrease of the atropine to prevent rebound phenomena.
Good. Thank you. I have a question regarding maybe the side effect. Now, with 0.1, do the patients usually complain of like mydriasis, or they cannot see well, or photosensitivity, or that is only with 1% or higher doses?
Much less adverse effect, less blur, less mydriasis, and less photophobia.
Sure. I see Dr. Samar is, Dr. Samar, do you have any?
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah. Tafadhali.
I want to congratulate Dr. Ilham for her thorough review of the topics. As you mentioned, this is a very hot topic in the field of research also as well. And I have just one question. You mentioned that there is no local commercially available product, right? So what about people who are getting it in private from Egypt and from Singapore? Is that now being a common practice here in Saudi Arabia? Because there are some patients who are coming with some bottles with 0.01%. That's the main question. The other one is about the refractive error. It would be really great to know if there is any ongoing school screening for refractive error to be started even prior to their as one of the preliminary tests to be included. Probably this could be a future, because when it comes, for instance, to the cornea diseases, more or less most of the common cornea diseases that we saw in Asia, usually, I mean, like in Southeast Asia, usually we have almost more or less similar in Saudi Arabia. For instance, like keratoconus, severities and everything is more or less similar to the Asian, not to the Caucasian. So I understand from Dr. Amal Hamidan that the genetics predisposition is not only the one main reason, and Dr. Ilham also highlighted according to her literature review, that there are some environmental factors when it comes to the reason why the patient are having progressive myopia. So are you aware of any ongoing school screening program here in Saudi Arabia? So these are my two questions.
Thank you, Dr. Samar. Up to my knowledge, there is a project in the Ministry of Health for the screening for children. I'm not sure if they started yet or not, but they are working on this project to make it as like vaccination, like a must for all children registering for school. But
Okay.
I'm not aware if it's started or not.
And what about these commercial available, brands, the patient are getting from Egypt, and
I saw some of the patients, they brought it from Egypt. It's and it's atropine with even 1%. Sometimes we are out of stock. So when they use it, it's okay, and they have same effect. So I don't think any problem if they use it and they brought it from abroad.
Okay. So hopefully that we will have one of the companies being registered here in Saudi Arabia to start prescribing it. Do you prescribe it for any specific degree of myopia, Dr. Ilham? Like a patient above 2 diopter, or what's your cut limits?
Usually
apart
I start
from the progression, yeah.
Yes, so usually I start to prescribe it if after following the patient and I saw there is a progression in their myopia. If it's more than -6 and the age of the patient more than 6, so I start to use it after seeing progression especially in the second year of their follow-up.
Okay, so your minimal refractive error is -6, not -2.
No, -6. Yes, I start to prescribe.
Okay, got you.
Can I comment, Dr. Abdullah?
Yes, Dr. Amal.
Yeah, I have started using the atropine on a patient with less than 6 because now if a patient, for example, at age 2 years, and he comes to me with a myopia of -2 or 3, now we know what's going to happen, right? He's going to progress more to myopia. So I usually, if the patient comes to me with a -6 or a -7 of myopia, I don't start him on atropine because I see no point in doing that. Because he's already, especially if he's 6 or 7 years old, I see no point in doing that. He's already got into moderate to high myopia range. What I have started using in my patient is to start them on low atropine, 0.1%, if they are, for example, 2 or 3 years of age and they are already -2 and above. At this age, he should be hyperopic. Okay, so if I catch him early, and this is what I'm doing with all my patients, if I catch him early, I start him on atropine. I make sure that he uses it. He's very compliant, and I explain to him exactly what he's supposed to do. If he's willing to get the bottle every week or 10 days from the pharmacy. But if I catch him at -4 or -5, I see no point in giving him anything. He's got to the high level of myopia anyways. So if we want to, as far as I'm concerned, if you want to have an impact on myopia progression using the atropine, I think we should agree that we should start it early before the patient gets to a high level. Because if he's -6, okay, just leave him. He will continue to have more and more myopia. But if you catch him at a high age and at a young age and you want him, and he at an age where he's expected to be hyperopic, and you start him on the atropine, this is where you should have an impact. Thank you.
Well taken point, Dr. Amal. There is one study that was published here in KCASH. I just want to talk about it. It was done by Dr. Rajiv, whereby they've studied refractive errors in orphan versus school children in Riyadh. So during World Sight Day. So the KCASH invited some of the children, and it happened that some of them were attending regular school, living with their parents, and the other ones who were living in, separately. And then they found that there was a significant myopia in children living with their parents, and it was up to 37%, which was much higher than those the orphan ones. So probably that lifestyle is different, as what Dr. Ilham was saying, that reading, concentrating on near objects, probably using devices, something like that, will contribute to that. That was just a comparison study, but could not reach a conclusion because it was not longitudinal. It was not following it up. But it's worth really knowing the habits of the children to know why some of the patients will develop myopia and others will not develop myopia. That's my last comment. And this article was published in Miejo in year 2020 for anyone who wants to read it. Thank you.
Interesting. Thank you, Dr. Samar. Regarding, Dr. Ahmad mentioned that if the patient has -6 myopia or 7, but can we think that if we started at -6 or -7, we want to prevent -13, -14? I mean, the progression from -6 to more than severer than that. What do you think, Dr. Ahmad?
You want me to answer? Now we know that for every 0.1 mm of axial length increase, you get 0.2 to a 0.25 diopter of myopia. So now how much of an axial length increase that you will get after age 6 years is what matters. I know maybe you will think that that you would want to prevent a higher myopia, like you mentioned. I have patients in my hands with a myopia of -19, who's 7 years old or 8 years old. Now you might have a point that why not start him, but if you are looking at if you want to assess the success of a treatment that you are is still under investigation, you don't get the very sick patients. But maybe ethically we should. But if you want to test is this medication effective or not, you will not get the very sick patients. You will get the patient whom, in your point of view, will most probably improve or get benefit from this particular medication. I don't see a point in not starting it, but because I'm doing research on it, I did not want to include patients with very high myopia on it. But maybe ethically, or maybe if I have it in abundance and I have no problem with the supply, maybe I should do that.
Yes, sure. Thank you, Dr. Ahmad. There is a question by Dr. Sisma. What about indoors and outdoors activities in the genesis of epidemic? I'm not sure if the question is clear to Dr. Ilham, or we can ask Dr. Sisma to tell us about it.
I think Dr. Ahmad already commented on that, her question.
Okay, so then we can take Dr. Turki bin Dakhil comment. As we know, now we have new emerging types of IOL which can improve peripheral defocus refractive error, which I think can decrease the progression of myopia in pediatric age group. Do you think using such technology will be the best IOL implanted in case of pediatric cataract?
I don't understand his question, because he put cataract with myopia. So
yeah,
I cannot.
I think if you allow me, as we know that when we implant IOL for pediatric, we think about the progression of myopia in case of IOL calculation. So maybe that's what he meant. Or let's ask him, Dr. Turki, are you with us? Can you tell us your point of view?
Yeah, my question regarding the new type of IOL, which is Art IOL. This type of IOL will correct not only the central astigmatism, but even the peripheral defocus, myopia, hyperopia, and all the refractive errors. So there is a theory that the peripheral defocus is the cause of progression. So do you think this IOL can tackle or address this problem, which is the peripheral defocus, which can result in progression of myopia in pediatric age group? So I was thinking, just if we can make this IOL as a primary IOL instead of the regular IOL that we are using now. This is my question. Thank you.
Actually, the phakic IOL, usually it's alternative surgical method, just in case of severe anisometropic myopia, but not but not used to prevent progression of myopia.
I mean, in case of pediatric cataract, so we will go for surgery. So do you prefer such technology over the current technology we are using now? Do you think it will make a difference?
Usually we in pediatric cataract, if we are planning to insert the IOL, we choose the power that correlate to the age to avoid myopic shift. So usually it depends on the case and the patient's age.
Thank you, Dr. Ilham and Dr. Turki. I'm not sure. Well,
Can I answer? Can I just comment again to Dr.
yes,
Turki?
yes, Dr. Ahmed.
When we implant an IOL in pediatric cataract, we target a plus. We target the patient to be hyperopic, depending on the age. For example, if the patient is 1 year old, and we go by the rule of 7, if, for example, he's 1 year old, we target the patient is to be +6. And so on, depending on his age. So taking in consideration that the patient will go into myopic shift in future. Now, some authorities have used bifocal intraocular lenses to help the patient to for reading after pediatric cataract removal. However, it's not very popular. Toric IOL have not been tested yet in a big group of pediatric cataract. Because simply we don't know how will these eyes act after extraction of cataract. So to use these special lenses with the peripheral defocus, it makes sense, but then you don't know, this was not tested in as far as I know, I haven't looked this up, but I haven't heard of any type of, what's the name of this IOL anyways? I'm not sure what's the name. But I haven't seen anyone or in my revision that was using even the toric IOL. Some authorities are just using the bifocal IOL, but not these special ones with the peripheral defocus. I'm not sure if anyone is using them. It makes sense, but it's not been tested yet.
Because Dr. Amal and Dr. Ilham, this type of IOL will be presented in the next ESCRS next week. So this type of IOL also you can change the spherical aberration induced by this IOL, which can by this induction of spherical aberration, we can enhance the depth of focus of this IOL. So it will enhance the near vision also as well after the surgery.
Yeah.
This type of IOL, you can select the spherical aberration induced by the IOL post-operatively. They have different types of spherical aberration induced, different amount of spherical aberration. So it might enhance reading.
Yeah, Dr. Turki, I mean, this IOL is in which phase? Is it in phase 2, phase 3, trial, or it's in post-marketing?
I think they are marketing it in Europe now, and they will present it in next ESCRS. Okay. It is about the inverted meniscus shape of the IOL.
Got you. Okay, thank you for sharing. Yeah. Okay, it's really a new IOL that I haven't heard about. Okay, but with regards to the toric, I just want to answer this. Regarding toric, I don't think that toric is a wise to be implanted in pediatrics because of the consistent changes in the corneal surface and the curvature with the growth of the cornea and with the time by the child. So there will be continuous change in the axis and shift. So toric is not an thing that can be done. Probably the future will be for the adjusted IOL, the light adjusted or something like that one. But planting a toric is not advised at all in pediatrics.
Thank you.
Thank you, Dr. Samar. So we have last question, and then I think we can conclude. The last question from Dr. Sisma: what is your opinion about performing refractive surgery in myopic children?
It's not advised at all. As we know, the consistent changes in axial length and cornea, and the normal growth of the eye doesn't slowed or stopped before age of 18. So I don't think it's a good idea to go for refractive surgery in myopic children, as well as the complication of refractive surgery in high myopia.
Can I comment, Dr. Abdullah? Would you allow me to comment?
Yes, Dr. Aman.
Now, refractive surgery used in myopia or in pediatric age group in general has its considerations. Astel and some group in Canada and USA, they are using some refractive surgery, but under special consideration, like for example, for the treatment of anisometropia. For example, if you get a patient with a plano in one eye and -12 in the other eye, you know that for sure this patient will become amblyopic in the other eye. So, and also in patients who have developmental problems, like for example Downs or cerebral palsy patient and others who have failed to wear spectacles and are in great need to do that because of myopia or whatever. Of course, if you have a patient with mental retardation or any type of syndrome that affects the mental development, and he is blind also, or he's very poorly sighted, then he is at a very high risk of getting injuries, self-inflicted injuries or others because of the poor sight. So there are some restrictions and some cases where we need to do refractive surgeries, and some authorities are actually doing them in North America, like Aston and his group. In the kingdom, we haven't started using that, and everyone is reluctant to do that. I myself have witnessed a couple of patients whom we did refractive surgery. They were Down's patient with a myopia of approximately -9 who failed to use glasses and were under continuous, all the time getting injuries and traumas because of the poor vision and failed to use glasses. And I know that their family were very happy after the refractive surgery because their life has changed. So there are some restrictions and some situations where you might be able to use refractive surgery, but of course we are not going to open this for everyone and for every patient.
Okay, thank you, Dr. Amal.
Thank you, Dr. Amal. Yeah, that's interesting point, and maybe our practice will change in the near future regarding refractive surgery in children. So is there any question or any comment before we conclude? I think we can conclude our discussion today. Thank you very much, Dr. Ilham, for this nice and great presentation. And I would like to thank all doctors who commented and also involved in this discussion and asked questions. Thank you very much and wish you to have a nice day.
Thank you.